Okay, good morning, everybody. Thank you, as always. As I always start off by saying, we're just going to give it a second for all of the attendees to join. We have, as usual, particularly today, a really important and I think very interesting topic with Dr. Parsonnet. Before we start with that, thanks, Dr. Pinsky, for that variant update.
I'll just start in with the post-vaccination infections that Brian was mentioning. So we've been helping to monitor this in healthcare personnel. There's been a total of 27 so far. This is right around 0.1% of the very large number of individuals that have been healthcare workers that have been vaccinated. Genotyping is available on 22. One is pending, 2 were tested elsewhere, and several had viral loads that were too low to genotype. Of those 22, the 15 had variants. 10 were the L452R, which is consistent with the California variant, or B1, 427, 429. There are 3 total B117 variants, one with E484K, which has been associated with P2, but could be other variants such as B1 526. Sorry for all the numbers and letters again. That's the one out of New York. And then we had one individual, as discussed over the last several weeks, that has the double mutant B1 617, originally identified in India. So as Brian mentioned, this really reflects the community prevalence of these variants in our patient population in our area. And there does not just seem to be an overrepresentation of these variants in vaccinated healthcare workers. And let's see if I can go backwards. No. Oops. Sorry about that. Get one more slide in to show you guys. Here we go. So this is our variant prevalence graph, just showing the mutations that we're screening. And as we discussed last week, the B117, represented here by the N501Y mutation, has overtaken L452R, representing the B1 427, 429 from California as the most common variant in our patient population. What you will notice is that there's been a bit of an uptick in the number of the B1 617 double mutant variants. There was a number of individuals that we have identified at the university that were infected with this particular variant. So that is our variant update for this week, and I'm happy to take any questions in the chat. Thank you.
As always, Dr. Pinsky, thank you so much for these great important updates. Just want to note that next week we have Dr. Eric Goosby, who will be talking about the post-pandemic, how COVID will transfer global health. Dr. Goosby is a director of global health and delivery diplomacy at UCSF, as well as part of President Biden's coronavirus task force. The following week, we'll be kicking off Asian Pacific Heritage Month in May with Drs. Palaniappan, as well as Dr. Lin, talking about Asian health, past, present, and future. And the week after that, we have Dr. Sarah Rudman, who is the Assistant Public Health Officer for Santa Clara County. We'll be talking about an update regarding the Santa Clara County COVID-19 response. But today we have a really important and really exciting talk by Dr. Parsonnet. Dr. Julie Parsonnet is the George Deforest Barnett Professor in Medicine and Professor in Epidemiology and Population Health, as well as a Professor in Medicine and Infectious Diseases. She also holds the academic appointments at Stanford, including a member of the Maternal and Child Health Research Institute and a member of the Stanford Cancer Institute. Dr. Parsonnet's interests involve interest in gastrointestinal infections, including H. pylori infection and diarrheal diseases, tuberculosis, illnesses with prolonged fever, and ways infections contribute to the development of chronic health diseases, including cancer, allergy, and obesity. She's a member of the Association of the American Physicians since 2017. A member was inducted in the National Academy of Medicine, or NAM, in 2019. She's also a member of the American Society for Clinical Investigation since 1998. She has been noted to have won the award of Best Doctors in the US multiple times, including every year from 2010 to 2016. She's gotten, no surprise, multiple teaching awards over the years at Stanford, very high prestigious teaching awards. And this is the abbreviated version of her, really her CV. But I want to highlight a couple of things that she's been involved with just recently. She's had hundreds of publications in her expertise, as well as presentations, chapters and books and so on. But I want to focus on a few things. Some of you may recall Dr. Parsonnet, along with Drs. Anand and Montez Roth last year, presented on the research work they did looking at COVID-19 antibodies in patients in dialysis. And this was a national study. It got national attention. And it was a really important study, particularly at the time when we were trying to figure out just how prevalent COVID-19 is. Dr. Parsonnet, along with Dr. Singh and multiple members of our community, was instrumental in setting up our COVID CTRU, Clinical Translation Research Unit, the outdoor really research center powerhouse that was created last year, for which is a big emphasis that we'll be talking about in this year's annual report. Dr. Parsonnet, along with her research partners, you may have remembered this story from January of 2020, where a study that got a lot of national press from Dr. Parsonnet, she came out with data that really pushed the understanding of what the normal body temperature is, changing our minds that it was no longer 98.6, but somewhere closer in the 97s. And this was a big story that we were hoping to have Dr. Parsonnet come and talk more about, but unfortunately the pandemic kind of ended up overshadowing a lot of that. And it's another article for which we're really excited to share in the annual report coming out soon. Dr. Parsonnet spent 6 months along with our own Dr. Dean Winslow at the McMurdo Station. That is one of the most desolate places on Earth in Antarctica for six months back in 2019, serving as the local doctor there along with Dr. Winslow. That's another one I was hoping to get you guys to come present about, but we didn't have a chance to since the pandemic came on. But Dr. Parsonnet has been one of the key people in the past year I particularly have relied upon for advice regarding sharing ideas and grand rounds and through our communications to update regarding COVID-19, among other things. I've been indebted to her. And of course, when we realized we wanted to hear someone talk about herd immunity, Dr. Parsonnet was the best person. Thank you to Dr. Singh as well for recommending her. Dr. Parsonnet is an expert in this field, among others. She's been in the news as well, being asked her thoughts about this. And I'm really interested to hear what she has today, talking to us about COVID-19 and herd immunity. Dr. Parsonnet, thank you so much for being with us today. I'll stop sharing my slides and I'll let you go and start sharing yours. Thank you very much for being with us again today.
Well, thank you very much for that just wonderful introduction. That's about the nicest introduction I've ever had. So thank you so much for that. So I actually don't consider myself an expert in herd immunity, but I am an epidemiologist, so I'm happy to take this opportunity to talk about it, and I have no conflicts of interest. So today I'm going to talk in this series of things. I actually gave the title Looking Back to Look Forward, because I think we have a lot to learn from prior infections and other things that have, other diseases that have wreaked havoc throughout the world for us to understand how herd immunity might roll out with, or not roll out with COVID-19. So I'm going to start with a history of herd immunity and history of the concept, where that concept came from, then talk about herd immunity versus disease elimination like we had with smallpox. I'm going to highlight 3 diseases: measles, smallpox, and flu. Then I'm going to talk briefly about a recent seminar that I'm going to invite you to all watch that was on the science of herd immunity by some of the leading modelers in the country. And then I'll give you my own interpretation of how I put this all together. So herd immunity was first discussed early in the 20th century, and not surprisingly, since it is herd immunity, not crowd or people immunity, it was about cows. And what Adolf Eichhorn noted at the time was that if he separated cows with brucella from cows without brucella, he could keep brucellosis from just spreading wildly throughout all the cows in the herds put together. And he noted too that the cows that were born in the infected herd would quickly get brucella, they would become immune, and they'd be able to stay in that herd. And he just had to keep the herds separated to prevent this wildfire. So he said abortion disease, which was brucellosis abortus, may liken to a fire which if new fuel is not constantly added soon dies down. Herd immunity is developed therefore by retaining the immune cows, raising the calves, and avoiding the introduction of foreign cattle. So soon after that, people began to look at it in other animals. And on the top left, you see this Dr. Topley, who was looking at mice. And he noted the same thing with mice, that he could keep outbreaks going indefinitely if he kept adding non-infected mice to cages that had infected mice, and he could keep infection continuously going. But if he let the mice, did not add uninfected mice, then the infections would die down and he'd have the same phenomenon of herd immunity. And then it was also noted in public schools in England by Dr. Dudley, who first started using the term in human beings, that the same thing happened with diphtheria in public schools. And this is a totally uninterpretable graph. I've gone through this graph about a dozen times, and I still can't figure out exactly what he's trying to say. But the crux of it is that when new students would come into school, diphtheria would again spread throughout the school. And when students had been there for a while and had been there for several years, it would all die down. You'd introduce new students, they get diphtheria again. And they were looking at the Schick test actually to look at the population herd immunity at that time. So what is herd immunity? Herd immunity is, as defined by the Oxford English Dictionary, is resistance to the spread of a contagious disease within a population that results of a sufficiently high proportion of individuals are immune to the disease, typically as a result of having been vaccinated against it. So the main thing that I think I would love people to take home about this is herd immunity is really about the number of susceptibles. What you're trying to do is to reduce the number of people who are susceptible to disease as much as you possibly can. It really has nothing to do with the number of, or very little to do with the number of infected people. You can have everybody infected as long as there's no susceptibles. You want to reduce the number of susceptibles through vaccination or naturally acquired disease. And here's an example of herd immunity, and I chose sheep here because they're herds. And the black sheep are infected. The white sheep are not immune and uninfected, and the gray sheep are immune. And this has an R0 of 2. So I'm going to mention R0 just a few times in this talk, but the R0 is on average the number of other sheep one sheep will infect. So in this case, infected sheep will likely infect on average 2 other sheep. And as you can see on the right is an uninfected population, and this central infected sheep will infect 2 sheep. It is actually exposed to these other 2 sheep, but it has an ineffective exposure. And then these 2 sheep will infect another 2 sheep. Well, this one's infecting 3 sheep, and this is an unsuccessful exposure. This one infects 1 sheep, ineffective exposure to these other 3 sheep that it sees. So now you have 1 sheep to 2 sheep to 4 sheep to 16 sheep, and that's how it would go on and magnify. On the left side is with vaccination. This sheep is also exposed to 4 sheep. 2 has an ineffective exposure. 1 is blocked by vaccination, and then it infects this 1 other sheep, and eventually it dies down. And it dies down because this population has herd immunity. And the herd immunity threshold is defined by that R0, and this is the higher math that I'm going to show you. Again, I'm not a modeler, so I'm not going to show you differential equations or Markov models or anything, or SER models. This is the higher math that I'm going to show you. The herd immunity threshold is defined as, in general, as 1 minus 1 over the R0. Here it's 2, so it would be 1 minus 0.5. So 0.5 is 50% vaccination would have herd immunity threshold in this population. Here you have 75% vaccination rate. So this would be herd immunity in this population, and this disease would die out as it does. You can see after the second generation, the disease is gone. So what is disease elimination? So we just talked about what is herd immunity, and then there's disease elimination, like we have with smallpox. And disease elimination is defined as the absence of endemic disease transmission that is continuous for greater than 12 months in a defined geographical area. So disease elimination usually involves two things. It involves herd immunity, so decreasing the susceptibles, and it also involves decreasing the effective reproductive rate. And you do that by putting in obstacles to transmission. So masks, social distancing, clean water, hand washing, all those things that are part of public health. So I'm going to start by the first, looking back historically at a triumph of herd immunity, and that's measles. And you could say the same thing here, by the way, if we use rubella or chickenpox, which I think have very similar triumphs. Measles first has noted in humans in the year 3000 BC, so it's been with us for a very long period of time. And it was introduced to the Americas in about 1500 by European colonization. So bringing one of the things which is challenging about getting herd immunity is that people move around a lot and they bring diseases around the world with them when they go. So the first thing I want to note, though, is that measles has been around for an awfully long time, and a lot of people have gotten sick with it, and we didn't get herd immunity. So I just want to point out that natural herd immunity is quite challenging. Here we have a disease, thousands of years, lots of disease, no naturally acquired herd immunity. The vaccine was introduced over here in 1963, we developed herd immunity following that introduction. But let's look now at natural herd immunity. I said we'd had it for a long time, and we have gotten natural herd immunity in isolated settings. So here's one isolated setting. In Fiji in 1874, it was introduced when the Prince Tomoko, who was a prince of Fiji, went to Sydney and came back. And when he came back from Sydney, they actually forgot to put out the quarantine flag on the ship. He was taken off the ship along with other people from Fiji. There was a meeting of the heads of the various communities after he got back. And within a few months, 40% of the population had died, greater than 20,000 deaths. But they had, for at least a time, herd immunity in Fiji. So herd immunity is possible, and it's particularly possible in very closed populations. So when you have islands or ships or herds or small groups where you have very few susceptibles who are continuing to enter the population, because again, susceptibles are the key component of herd immunity. As long as you don't have susceptibles continuing to wander in, then you'll have herd immunity. But of course, you always do have susceptibles wandering in because you have children being born, and children are born susceptible. And so that's what happened in Hawaii. So in Hawaii, they also had no measles before the colonization. And in 1824, the king and queen of Hawaii both died in England of measles on a visit there. But there was still no measles in Hawaii until 1848, when somewhere between 10 and 33% of the population died of measles. And then there were subsequent epidemics. Basically, each time there was enough newborn children to have a highly susceptible population. So there were outbreaks again in 1861, 1889, 1898, and again in 1936. And the population of Hawaii went from 135,000 in the mid-19th century to 53,000, 54,000 later in the 19th century. So it was a tragic consequence, but it does show again that herd immunity is something that requires constant attention. It's not something that you get herd immunity and you say, oh, we're done, because unless the whole world is immune, and unless the whole world, the disease has been eliminated, there's constantly going to be regeneration of susceptibles. So I do want to say that we did, going back to this original graph, you can now see that there are some red bars on there. And the red bars are when, again, we introduced vaccination on the left, and when in 2000, we declared herd immunity, or that we had essentially eliminated disease in the United States. of measles. So he had eliminated endemic transmission. So then the question is, what enabled this herd immunity and the elimination of measles in the United States? And I want to say, first thing that was most important in eliminating it is that we already had very close to herd immunity. So here's a graph that was done from a serosurvey done from serum that was obtained between 1999 and 2005. And they adjusted it looking at the birth years. And so on the left, you can see the people, those black dots are people who were born between 1949 and 1957. And you can see that in 1999 and 2005, when they were tested, they were all immune. And the reason they were all immune is measles was so common, and all these people had had measles in childhood. And natural immunity to measles does provide lifelong immunity. So we came to measles vaccination at a point where 95% of the population was already immune, or yeah, over 95. Here it's a 97%, 98% was already immune. So all you had to do was vaccinate children. We didn't have this daunting problem of vaccinating everybody. In addition, we had a very high efficacy vaccine. Initially, it was given with 1 dose, which was 93% effective, but with 2 doses, 97% efficacy. Very long duration of vaccine efficacy. So the vaccine is not like the natural immunity. It doesn't last quite as long, but it lasts at least 15 years. The other thing that we have that helps us with measles is that cases are symptomatic, and that pretty much only symptomatic cases transmit. Now, they may transmit before the rash, but they're usually symptomatic at the time. So you can find people, and the vaccine is effective even after you've been exposed. So if you have somebody who's has measles, you can do ring vaccination around them and then prevent transmission. The other thing about measles is there's no animal reservoir, so we don't have that whole other group of susceptibles we have to worry about, which is the animals that we live with. And even despite all those things, and despite enthusiasm for the measles vaccine, it still took 40 years for us to eliminate it and to really end endemic transmission. And the downside too is that we're the only place that really has eliminated measles. These are the measles rates and where they are around the world today. There's 300 deaths from measles per day in the world. And this map shows the areas in which proportionate amount of measles cases, and the bottom left is a case of measles that I saw in Africa. So people do move, and we do see measles come to the United States, but so far we haven't had a lot of endemic transmission until 2019. And on this graph, you can see on the red line is the number of cases we've seen in the United States since 2001. And I'm sure you could see, and the axis on the left shows the number of cases per million. So first of all, I want to just note that this is a very low number of cases. It's 3.7 or something like that cases per million population per year. So we're not talking about a huge number of cases, but you do see that it's taking off. And the other thing that's interesting is these blue bars, and the blue bars, the axis is on the right. This is the proportion of cases that are imported. And you'll see in the early 2000s, the number of the proportion of cases that were imported is high, somewhere between 40 and 70%. But now what we're seeing over the last 5 years is that we're seeing more endemic transmission. We're seeing more, even though the index case may come from overseas, there's actually native transmission, endemic transmission within the United States. And the majority of cases are transmitted to people within the United States. And this tells two things to us. First is that herd immunity in a world where disease still exists, in a very interconnected world, is extremely hard to even entertain. And it also shows that we are not up to date with vaccines. We have a lot of vaccine hesitancy. And again, we need a lot of attention to keep herd immunity possible. After 60 years of vaccinating, it's not clear we now have it. And in April 2020, the WHO indicated that many countries had stopped their measles vaccination programs due to the impact of COVID-19. And it's projected that there are 117 million children who will be at risk of infection in this year. So now switching to smallpox, spelled wrong, without the space. a triumph of eradication. So this is going to be a little bit different between herd immunity and eradication. So this is, as we all know, smallpox was declared eradicated in 1972. And you can see that it has marched around the world. So initially it was eradicated in Scandinavia, and subsequently in Australia and Madagascar, and then later in Asia, United States, and finally in the 1970s in parts of Africa and India. But it wasn't an easy thing to do. Edward Jenner pushed the vaccine starting in the end of the 19th century in the 1790s. And so they started vaccinating around the beginning of the 19th century. These are the number of deaths per thousand in England after vaccination started. And it's 1 per thousand deaths. You see on the at the onset of this graph, that's a lot of deaths per year, 1 per thousand from an infectious disease. So that's a pretty bad disease. And along the way, they had a lot of blips that came throughout that time, including a big blip in the Victorian era in the 1870s. And the reason they did is because there was a lot of objection to vaccine. It was a huge issue in England and the United States and throughout the world. The left vaccine is, I think all of these are from the United States. But it actually is where the term conscientious objector came from, because they asked, in England, it became required that you get vaccinated. And it became a huge brouhaha when the vaccination laws said you have to get vaccinated. And so they came up with a strategy that if you could get 2 letters from several doctors and your priest that you did not have to get vaccinated, you could be a conscientious objector. And with that, actually, the vaccination rates went up. Once people knew they could opt out, they said, well, it's too much work to be that conscientious objector. I'll just get the vaccine. But nevertheless, there were laws in the United States that you had to get vaccinated, and they actually had people raiding households to vaccinate people. And there was one episode that I'm going to quote from a book that I read that says there was an episode in Middlesburg, Kentucky, where the police and a group of vaccinators went into an African-American section of town, rounded up people outside their home, handcuffed the men and women, and vaccinated them at gunpoint. It was a shocking scene and very much at odds with our notions of American liberty. So that was from 1949 in the United States. And the bottom right is a picture that people use to get people to vaccinate. This is actually from Leicester in England, of a pair of twins, the one on the left not vaccinated and the one on the right vaccinated. So what did enable the elimination of smallpox in an era even with vaccine hesitancy? Well, first, again, they had an excellent vaccine. It had an efficacy of 95%. Again, they had a vaccine that worked during the incubation period. So the incubation period is 10 to 14 days. So if you could find cases, you could vaccinate people around them and do ring immunization. And the vaccine had pretty good duration, 3 to 5 years. People were not infectious prior to the onset of disease, and you have a very characteristic disease with characteristic skin lesions. So it was pretty easy to do circle vaccination because you can find those remaining cases and vaccinate them. And again, there's no animal reservoir. And it's a picture of the circle vaccination going on in Congo in 1962. So if you would ask Bill Foege, did we conquer smallpox with herd immunity, he would say no. And this is a quote from his book. Experts from India, from WHO, and from CDC all concluded that since 80% coverage was not being achieved, that's the number that they needed for herd immunity, the goal needed to be to increase it to 100%. That makes no sense. If you can't reach 80%, you certainly can't reach 100%. The herd immunity concept was promoted, yet remains unexamined. So after 200 years of vaccination and thousands of years of disease, smallpox was conquered not by herd immunity alone, but by enhanced surveillance and containment. So how are we able to control influenza? So we're getting to another vaccine preventable disease that we'd love to get herd immunity to. And the answer is we haven't been able to conquer influenza, despite now vaccinating people since 1943. And but we have done a really good job this year. We've had really little flu. It's at the bottom line there in those triangles. We've almost eliminated flu in the United States this year, and we did it with masks. So vaccination is one part of the armamentarium to getting towards elimination of disease. It is only a single part. And why have we not been able to control flu by vaccination and by herd immunity? Well, first of all, the vaccine has to be good. What I showed you with smallpox and measles, you have to have a really good vaccine, and the vaccine for flu is not so good. The vaccine efficacy has been as low as 30% and even lower in the elderly. And it has to work in all parts of the population. It can't just work in one age group, it has to work in everybody. It's good if it also prevents transmission, and it's not always clear. I think with influenza, it does prevent transmission, but it has to be a good vaccine. The second is elimination of disease is easier if you don't have it in animals. And flu is very widespread in animals, in ducks and in pigs, and they cause not only a reservoir for disease, but also provide an opportunity for mutations in the virus. And that's another problem with getting herd immunity, is you have all these variants that occur and all these genetic changes, shifts and drifts in influenza that prevent the vaccine from being effective. And we don't have a universal influenza vaccine that is able to prevent all flu infections. And then you have to remember that we live in a very interconnected world. We're not in isolation. And as soon as susceptibles move around the world, you can have one person with infection moved into a group of susceptibles, or you have susceptibles come into a previously infected population. We are all interconnected. And to think that we can get herd immunity in an interconnected world is extremely challenging. And the other reason we don't have herd immunity to flu is because we have a lot of objectors, a lot of people who are vaccine hesitant. So now I'm just going to take the slide and say that these are all problems that we also see with coronavirus, with COVID-19. For SARS-CoV-2, we actually have a really excellent vaccine. I think the vaccines we have are just a triumph of science and really good. Maybe not as good as measles and smallpox, but pretty darn good. And so I think we should be very excited about that. We don't know how long they're going to last, which is another criterion that you want for a vaccine, because every time you have to give a booster, you're going to start losing people along the way. We do also, COVID has animal reservoirs, which is going to make it, again, more challenging to eliminate it. It's not clear that we acquire infection from animals easily, but it does provide an opportunity for the virus to mutate and to transform into potentially more virulent forms or more easily transmissible forms. And to date, SARS-CoV-2 has been found in minks, cats, dogs, voles, ferrets, fruit bats, hamsters, gorillas, pigs, rabbits, shrews, and white-tailed deer. And we know that in cats, ferrets, fruit bats, hamsters, and deer, they can transmit it among themselves. And there has been transmission in a mink farm from a mink to a human. So we have this whole other source of infection that we haven't yet really had time to address and see whether it has any significance for our being able to eliminate the disease. Also, this RNA virus mutates a ton like flu does, and that could be a good thing or a bad thing. And we may have vaccine escape mutants, and we also may have it mutate to become less virulent over time. So we'll have to wait and see. But that's another challenge for herd immunity that we don't see with smallpox. And we have a lot of travel, and we have a lot of vaccine hesitancy. So these are issues that I think are going to be a challenge. So I want to mention that, again, I'm not really a herd immunity person, and I'm not a modeler. And that's where herd immunity is most effective, is looking at models. And I think herd immunity's great asset is that it allows us to understand what sorts of interventions are going to be most effective and how we do them. There was a recent seminar that we had at Stanford that was run by Erin Mordecai from the Department of Biology and Mallory Harris, who's a Knight Hennessy Fellow in biology, that they put together that was really terrific. And I encourage people who are more interested in this topic to go to that URL that I put at the bottom, where it's a YouTube video, and they have really terrific talks. that were given by Lauren Meyer from UT Austin, Mark Lipsitch at Harvard, and Rustam Antia from Emory, who was talking on behalf of his team. And I'm going to just actually now just take a minute to show you a few of the things they said that are more about the science of herd immunity. And again, I hope I represent them well. So this is one of the first points that Lauren made, and it actually is from a graph that was from an editorial by Carl Bergstrom at University of Washington. And he said about natural herd immunity and the effort that we have to have natural herd immunity, that people forget that once you get natural herd immunity, which is right here at this point on this graph where that arrow is, disease doesn't stop. And if you look at that red curve at the bottom, there'll still be active infections that happen because you've hit the peak when you have herd immunity, and then you're going to have this long tail. And you're going to still have that whole area of blue of still more people getting infected. And so you're talking about when you have natural herd immunity, that you may hit herd immunity at maybe 60% of the population being infected, but you're still going to have 25% more population still get infected, and a lot more people are still going to die after that herd immunity threshold is hit, because you're going to have the disease still tailing off. So it's not, you're not going to have this magical aha moment when you hit that natural herd immunity, if you ever attain that point. And I will say that we are still a very long way from natural herd immunity. The other more positive thing, though, is that Lauren brought up, this is not her slide, but one I pulled up instead, is that populations are not homogeneous. And there are some groups that spread a lot of disease and other groups that spread very little. And this is a representation of it by a professor at Max Planck in Dresden, where he said, well, let's say you have a disease that has an R0 of 2.5, and you have a homogeneous population where disease is random, then you need 60% herd immunity at that setting to actually prevent disease. But let's say you have a heterogeneous population where some people stay home and some people don't have very many friends, and so they don't transmit very much. And another section, a proportion of the population, is really of partiers. Well, then you can really attain herd immunity if you attack that group, okay? If that group becomes immune, then you can actually get, and they will be more likely to get immune quickly because they're out there all the time. You can actually attain herd immunity at a much lower threshold. And to me, this is the most important thing about this, is how we consider vaccination. So the way we've considered vaccination in the United States is to get the elderly vaccinated first. And that is going to prevent deaths. Very, very important. So I have no problem with getting the elderly vaccinated first, and the people who are at highest risk. But the next effort has to get the partiers. It doesn't have to get the people who are getting vaccinated now, which are the very careful people who are being really, really good about managing their exposures. What you want to get is the people who have a lot of contacts and who are out there and in that heterogeneous population are the ones who are transmitting infection. And that's the challenge for us in getting herd immunity, because a lot of those people are the people who are resisting a vaccination, young adults who don't really want to get vaccinated, and a lot of minority populations that are some of our essential workers who are suspicious of the vaccine and who also live often in high density housing and with extended families. And so if we really want to approach this, it's the people who are actually hardest to vaccinate that are going to be the biggest bang for the buck and allow us to get by and actually diminish the rates of disease. The other thing, and this is actually, again, another slide that I adapted from one of the talks by Mark Lipsitch. And he said, well, you know, we're just talking about the vaccine efficacy, but it has to also prevent transmission. And we don't really know yet how much the vaccine prevents people from still acquiring infection and transmitting it to other people. But the thought is that it is about 70 to 80% effective at preventing transmission. So people who are vaccinated may not get sick, but they may still have get colonized, and it may it may prevent them from transmitting it about 80% of the time. And you can see I've modified this HIT equation I showed you before with that chi at the bottom, which is how much transmission is prevented. So on this graph, on the x-axis, you see the R naught, and on the y-axis, you see what would be the herd immunity threshold you need to hit to prevent transmission. And in that dark blue line on the left, if transmission is not prevented very well, then anything over a herd immunity threshold of 1 means you're ain't nowhere going to get there. You have to have over 100% of the population vaccinated. Okay, not going to happen. So, so if you have a lot of if the transmission is not prevented by the vaccine, we're not going to get herd immunity. And this is where we think we are as a population, that the R naught is probably somewhere around 2.5 to 3.5. There are some studies that have it as high as 6, some have it as low as 2, but that's about where we are. And again, we think that we probably prevent 70 to 80%. And so we need to get at least 75% of the population, 85% vaccinated for us to prevent transmission with those numbers. And there's still a lot to learn to know that those are right. So the last point from that conference was by Rustam Antia, who's at Emory University and who was speaking on behalf of people he worked with. And then the question he was saying is, what happens if we don't get herd immunity? And he gave a very optimistic picture, I think a little bit more optimistic than I would give. But his point was that if we don't, when the virus comes into a population, it hits all age groups. To a naive population, it hits all age groups the same, because we're all naive to it and it'll hit this all. But as the disease goes on, people age out. And so as you get older, you've had multiple opportunities to get exposed. And after a number of years, all the older people will have been infected. And the only people who are susceptible will be the young people who've not been exposed or haven't been vaccinated yet. And unlike measles or smallpox, that's not as bad a thing with COVID, because young children and generally have a very mild disease and they don't die. So the thought is, if we don't actually gain that herd immunity, what we may see is that the proportion of primary infections, which is in the blue line, will be largely in younger people, in younger adults as time goes on, and that the death rate will drop dramatically. And this will end up being an endemic disease that will be largely of children and also some of the elderly who are unfortunate enough, and the older people who are unfortunate enough not to have established immunity or to have lost their immunity. And the reason I think this is a little optimistic is because we really don't know how good immunity will last for COVID-19 at this point. So I'm going to end with a few just thoughts of my own. Will we get to herd immunity? I have absolutely no idea. I think it's unlikely personally. And I think there's increasing numbers of people who work in this field who also think it's unlikely. But I'd like to stop talking about it. And I think herd immunity has been taken from where it is best used, which is in modeling, and has become this mantra. And I don't think it is a very useful topic. I think instead we should be talking about decreasing susceptibles. That's what we should be working the most at. And the way we're going to decrease susceptibles is by vaccinating as many people as we possibly can. And every single person who is vaccinated, whether we attain herd immunity or not, every single person who is vaccinated protects all of us. And every single person who's vaccinated in Africa and in Latin America and in Indonesia, every single one of those people protects all of us. And our goal has to be to push out vaccine as far as we possibly can. We also have to be cognizant that we can still mitigate exposure. And until we know that we are safer, we should be wearing masks and doing all the things that the public health department says that we need to do. And we also need to really be good about surveillance and response. And I think we have not been as good about that as we should be. We should be having much, much more at-home testing, point-of-care testing, so that we can identify people who are likely to transmit it. This is not like smallpox and measles, where you're going to develop a rash and everybody knows to stay away from you. This is a disease where that is often silent, and without having very frequent testing and at-home testing and people who are really monitoring that, we're not going to have a good shot at this. I'll say that without any vaccine, New Zealand, Australia, Taiwan, and a number of other countries, just using those latter two, have managed to eliminate infection. So it's not that we need vaccines entirely. But there are countries like Israel that have done a great job getting close to herd immunity. But I will say on top of that, they also have done a tremendous job with surveillance and with testing everybody who comes into the country and vaccinating people who are unvaccinated who come into the country and keeping them quarantined and testing them. They've done a really good job on virtually all aspects of this. And that's why we're seeing such great success in Israel. So in conclusion, herd immunity is a very useful tool for modeling policies. In the real world, natural herd immunity is nigh impossible. You need vaccines. We're a very connected world. We need, this is an asymptomatic disease that also involves animals. Not likely that we're gonna get herd immunity, and certainly not naturally. Disease control is most successful when you use a mixture of methods, and I totally admire our public health departments around the country that have been pushing this all along. We need to decrease susceptibles through vaccination. We need to have good surveillance and response, and we have to mitigate exposures. So that's all I have, and I'd really like to thank a number of people. As Errol mentioned, I was in Antarctica, and actually pretty much exactly a year ago, I was supposed to give grand rounds about Antarctica. So this is my anniversary of that talk. I want to mention that this is a penguin I saw there, emperor penguin, but unlike that penguin, I don't do any of my stuff alone. And I really want to just take the opportunity to thank my peeps in infectious diseases who have just been fantastic at dealing with COVID, starting with our fearless leader, Upi Singh, but Hector Bonilla, Jason Andrews, who taught me everything I know about herd immunity, by the way, Pras Jagannathan, Aruna Subramaniam, Marissa Hullabar, Karen Jacobson, Lucy Tompkins, Phil Grant, Ann Liu, Shanti Kapagoda, and everybody who works in the tent, who's been really, all these people have been working so hard on COVID. And then my lab members who worked for me for, I think, about a total of 100 years now, Kat Lay, Tom Haggerty, and Lou Sanchez. And then I just want to also thank the COVID testing czar, Dean Winslow, who for the United States, who also is an expert in penguins. So thank you very much.
Dr. Parsonnet, I'm still looking forward to hearing about Antarctica sometime in the future from you and Dr. Winslow. We'll have to schedule that for another time. Thank you for this talk. No surprise, there are already 11 plus questions, so that means there'll be many more coming. So I'm going to try to get to as many as possible. Just a reminder, everybody, please upvote the questions that are out there to help me figure out which ones to ask. Dr. Weinberg mentions a great informative talk. Thank you. Is it time to retire the term herd immunity and replace it with community immunity, which both appeals to the anthropocentrism and emphasizes societal responses to each other?
I think that's a great question, and I think there. Yes, I think I don't know what the right term is. I think community immunity is a great term. I think disease elimination is better, or disease control, community control. I don't know what the right term is. I will point out that one of the things that was mentioned by Lauren Meyer when she gave her talk is this very important thing of community, that community is terribly important. And she showed maps of Austin that showed basically the socioeconomic status of various parts of the community and where vaccination was happening and where disease was happening. And there was, not surprisingly, a lot of correlation among those things, that vaccine wasn't happening in communities that had the highest rates of disease, and there were socioeconomic features of those communities that were very apparent. So I do think that there's a real asset to saying something about community and to telling people that they should work on their own communities and improving the elimination of disease from their communities by all those measures, both through immunity and through containment.
Next question by Wesley Park. It seems that children are extremely low risk of serious disease and from COVID and do not transmit the virus effectively. How does this affect your thinking on herd immunity and the quote badness of infections? It's also noted they can still transmit and perpetuate infection.
Yeah, so that gets to that last slide one of those last slides from that session I talk about. If we can get enough adults vaccinated and disease was restricted to children, we would have to children who are not vaccinated, we would have a much lower mortality rate for sure. And it would be restricted to the adults who are not immune, or those few that are immune who are very unlucky, and be largely a disease of children. We don't really, I'm not going to say with great certainty that that's okay. I mean, I think it's likely what's going to happen, that it will become a disease of childhood with less disease in adults. But I don't know that we don't really know yet the long-term consequences of COVID in children. There are certainly some children who die of it. We don't know what's going to happen with variants in children, and we don't know whether there are longer-term long COVID possibilities in children. So I think there's still a lot to learn about that. But I do think that is one very possible scenario, is that we end up with a mild childhood disease.
Dr. Tang asks an interesting question. He also notes that what an exquisitely clear and informative talk. Thank you, Julie. Since herd immunity is really a combination of science, disease, and human psychology and behavior, do you think we accomplish eradication of herd immunity for smallpox and measles, because smallpox is visually disfiguring and measles affects fetuses?
I think you hit on some very important things here. I think smallpox we were able to eradicate partly because of that, because it's disfiguring, because it's highly lethal, 30% mortality. So it's a highly lethal disease. And because there was a really can-do attitude of the World Health Organization, CDC, and many countries that really felt we could do this and really, really pushed it hard. It was a very international effort that I personally find very challenging right now to see when we're ever going to get an international effort as effective as that again. I think measles, again, part of the reason we could do it was it's children that were dying, and parents are scared of having their children die, and there was a bigger push to protection because of the childhood mortality. And also, again, it was a different era, but I do think that children being infected is much more threatening, and also children are much more easy to capture by vaccination than other populations, because they come in regularly for checkups.
Dr. Leibowitz asks, what's with the Scandinavian countries on the measles homunculus map? Don't they vaccinate?
They do, but there's a lot of vaccine hesitancy in Europe now, a ton, especially in Eastern Europe, but all over Europe, done a ton of vaccine hesitancy, and that's responsible for the rise of measles in Europe. So yeah, I'm afraid that's still the problem. There's a problem everywhere in the world.
Do you think Israel has reached herd immunity?
I think it's very likely, or very close. Yes, I think the answer is probably yes. But will they be able to maintain herd immunity is another question. I think it's easy once you've reached that point to become cavalier and take down your guard. And we see that that's happened with measles in the United States, but it's easy to take down your guard. There are people coming into the country, there are children being born, there are a lot of people coming in from areas that have high rates. And we don't know how long the vaccine will be effective, how long it will last. And so it'll be interesting to see. They've really opened up in Israel now. They're not wearing masks. It'll be interesting to see how long it can be, whether it can be maintained and how long it can be maintained.
Next question here. Is there a rationale to routinely checking MMR titers in our non-US born populations in order to decide who is susceptible to measles and vaccinate them?
I'm sorry, can you say that again? I missed part of it.
Is there a rationale to routinely checking MMR titers in our non-US born populations to decide who to vaccinate?
Well, first of all, I don't know that it matters where you're born about who to vaccinate, because vaccination actually is much better in a lot of countries in the world than it is in the United States. So I think the United States is one of the world leaders right now in vaccine hesitancy, and so I don't know that. And some of those people are now young adults who should have been vaccinated. So I don't know that it's incumbent on us to look from people from around the world. We might try to look at countries that have low vaccination rates. and try to think about it that way. But I don't think it's going to be, I think it would be a challenging thing to do. We do have a place where we do that, and often on the way into college or graduate schools, they will do titers of people going into schools and say, you know, you need a booster. There, but I don't know that that would be a very effective strategy, because I think most people coming in would be immune. I'd have to think about it. It's a good question.
I'm going to combine these next two that touch on children. One question is asking, lots of contact populations also include children in school. What are your thoughts on that? And then another question also asking, what are your predictions if children eventually get vaccinated?
You know, I think it'd be great if children were vaccinated, if we had it as part of our annual. So to attain herd immunity, we're going to have to be vaccinating for a long time. That's how I would feel about it. We'd have to be vaccinating people, not just, I mean, look again at measles, where we had a highly effective vaccine, 40 years of vaccination, we actually ended up with, you know, really good herd immunity. It's not going to happen overnight. It's going to have to be something that goes on for a long time. And if we really want to attain it, then yes, we do need to vaccinate children. And children, again, are among the easiest groups to actually corral and vaccinate. Adults are the harder part, right? But vaccinating children is often a very effective strategy to prevent disease in adults. We know that in influenza, that vaccinating children prevents adult disease because children are a source of transmission. So I imagine that we will be vaccinating children into the future, provided the studies work and that the vaccine works in children.
Dr. Parsonnet, as we're hitting 9 o'clock here, I thought I'd wrap up. I do want to mention that there's a number of comments simply saying what a wonderful presentation, and thank you so much for being with us today. And I just want to add to that as well. Thank you again, like I mentioned in the intro, for everything you've done for us, particularly in the past year, and again for being here today to help us understand herd immunity. Thanks to all our panelists, and of course all the attendees for sticking with us through the hour. I hope everybody has a great rest of the week and a great day. Thank you so much.
Thank you so much. Thank you.
Bye-bye.